What?
Did really well?
Yes, we did very well in the group. We did very well. Okay, so I'm not sure if we're gonna make it for midterm exam week.
Damn. Oh, bummer, dude. Really looking forward to it.
I think we have Monday off, so that's gonna take another 2 hours out of our schedule. Okay, so we were talking about, again, some different main groups of pulmonary pathology. We subdivided them into obstructive and restrictive. Remember, the main feature of obstructive is a reduction in the forced expiratory volume per second. The main characteristic feature of restrictive pulmonary disease is a reduction in the forced vital capacity. We're going to talk about restrictive diseases today. Restrictive diseases can be subclassified as either acute or chronic, depending upon how quickly the forced vital capacity is reduced. Remember, the forced vital capacity of the lung is reduced because the lung doesn't expand very well. Something's preventing the lung from expanding. That will reduce the forced vital capacity. Now, again, we've got acute and chronic subdivisions of restrictive. Acute, because it happens relatively quickly. Usually, the reduction in FVC is quick, and it's a transient reduction, meaning that the normal FVC will return eventually. Chronic restrictive lung diseases, on the other hand, are characterized by an insidious reduction in the forced vital capacity, and it's usually irreversible. The important thing to remember about chronic restrictive lung diseases, they're generally all caused by scarring of the interstitium of the lung. That's a common feature you see with these chronic restrictive lung disease. You got scar tissue in the lung. Now imagine if you have scar tissue in the lung, the lungs aren't going to be very compliant. They're not going to be very elastic. You're not going to be able to distend them. And as a result, you develop these restrictive lung diseases. So virtually anything that causes interstitial scarring in the lung is going to cause a chronic restrictive type of lung disease. Okay, we're going to start off with the acute restrictive lung disease. And the first thing we're going to take a look at would be the acute respiratory distress syndrome, ARDS. It was formerly known as adult respiratory distress syndrome. Now we call it acute respiratory distress syndrome. Again, characterized by an abrupt but transient decrease in the forced vital capacity. This is usually caused by some sort of acute lung injury. Something injures the lung. Could be inhalation of something toxic, could be some inhalation of something thermally damaging to the lungs. Whatever be the case, there's some sort of acute lung injury. Generally within 72 hours of that acute lung injury, there is a degeneration of the type 1, type 2 pneumocytes and the pulmonary capillary endothelial cells. They all start to degenerate. And as those cells degenerate, the alveoli start to become coated with a lot of this necrotic material. So now you got a lot of necrotic material in the alveoli. That really reduces the ability of the alveoli to expand. Also, at the same time, when this necrotic material is accumulating, the immune system responds by infiltrating the interstitium of the lung with lots of inflammatory cells. The inflammatory cells further reduce the compliance of the lung. And so as a result, very acutely, you have a reduction in the forced vital capacity. This is what happens with acute respiratory distress syndrome. Okay, let's take a look at some of this damage that's done to the lung. We can subdivide this disease into two phases. There's something called the exudative phase, where all the damage occurs and there's all that degeneration. And then there's something called the proliferative phase, where a lot of the damage is being repaired. Let's take a look at the exudative phase of this disease, ARDS. Okay, first of all, let's take a look at an example of what can cause this. One of the frequent causes of acute respiratory distress syndrome is septicemia, particularly by gram-negative bacteria. Gram-negative bacteria trigger the immune system to attack the lungs. And then there's this degeneration of the type 1 and type 2 pneumocytes in the pulmonary capillary endothelial cells. Let's take a look and see how this works. We have a section through one of the alveolar walls. You can see the alveolar spaces over here. It should be filled with air. This is the wall of the alveolus, and inside the wall of the alveolus, you have a pulmonary capillary. Now, in a gram-negative septicemia, the bacteria break down and release endotoxin. It's that lipopolysaccharide component of their bacterial wall. That's called endotoxin. And this endotoxin accumulates in the blood, causing an endotoxemia. Well, the immune system responds to this endotoxemia, and the endotoxemia has a number of different effects on both white blood cells as well as the pulmonary capillary endothelial cells. Here's the blood vessel of the pulmonary. This is one of the pulmonary capillaries, the blood vessel. You can see it's lined by these endothelial cells. A lot of endotoxin enters the pulmonary capillary and has an effect on the gene expression of these pulmonary capillary endothelial cells. They change their gene expression to increase the density of adhesion molecules on their surface. At the same time, this endotoxin is changing the adhesion profiles on these endothelial cells. They're also activating these white blood cells. White blood cells increase the expression of their receptors, which are complementary to these adhesion molecules on the endothelial cells. So now the white blood cells come in here, they're activated, and they start sticking to these pulmonary capillary endothelial cells. And when they start sticking to the pulmonary capillary endothelial cells, they start elaborating a lot of digestive enzymes and free radicals. This is what happens. Okay, again, alveolar space, there's the pulmonary capillary. These white blood cells are now sticking via these adhesion molecules. They're active, they're elaborating a lot of proteases, free radicals. That starts to damage the pulmonary capillary endothelial cells. One of the features that characterizes acute respiratory distress syndrome is a degeneration of the pulmonary capillary endothelial cells. There they are, they're starting to degenerate. Okay, but that's not where the damage ends. These white blood cells penetrate the wall of the pulmonary capillary, entering into the airspace in the alveolus, cross over to the alveolus, where they still elaborate free radicals and proteases. And these free radicals and proteases also cause degeneration of the type 1 and type 2 pneumocytes, which also characterizes acute respiratory distress syndrome. And so now you've got these degenerating endothelial cells. Now you've got these alveoli that are lined by a lot of necrotic material, which are the remnants of the type 1 and type 2 pneumocytes. And that's another feature of acute respiratory distress syndrome. Now, all this necrotic material lines the entire alveolus. And when you stain it with H&E, it stains this very dark, kind of pinkish color. And another name for pink is hyaline. This pink necrotic material that lines the whole alveolus looks like a membrane. It's really not a membrane, but it looks like a membrane. And so at one point, ARDS was referred to as hyaline membrane disease, hyaline membrane disease. And it's kind of a obsolete term for ARDS, but that's where the name came from, because the entire alveolar space was lined by this necrotic pink stained material that looked like a hyaline membrane. Okay, now this is what happens in the damaging phase, what we call the exudative phase of ARDS. There's a lot of exudate, a lot of proteinaceous material in the alveolus and in the interstitium of the lung. Let's take a look at what the exudative phase of the lung looks like. Here is an example of a section through a lung taken from someone with ARDS. Okay, you can see we got the air spaces here. These are all alveoli, all air spaces. And you can see the interstitium of the alveolus here. Okay, all the interstitial areas of all the alveoli. And you notice that the interstitium of the alveoli are very thick. The walls of the alveoli are very thick. And that's because they've been infiltrated with a lot of inflammatory cells. All of this necrotic material provokes an inflammatory infiltrate. The inflammatory infiltrate gets into the walls of the alveoli, making the walls of the alveoli very thick. Now, these thick-walled alveoli are very difficult to distend, and that reduces lung compliance very quickly. Look at the alveolar walls themselves. There's the alveolar space. Look at the walls of the alveoli. See this kind of red, pink staining material that's lining the alveolus? Take a close look. Let's zoom right in. Okay, here's one of the alveolar spaces. You can see the walls of the alveolus here. Look at all that pink stuff within the alveolar space. That's all necrotic material. Another name for pink is hyaline. This kind of looks like a pink membrane, so we call it hyaline membrane disease. Take a closer look at the walls of the alveolus. It is infiltrated with a lot of inflammatory cells. Together, this necrotic tissue in the alveolar space, along with this inflammatory infiltrate in the interstitium, that reduces the lung compliance very quickly and significantly. And so when someone has an acute lung injury, and this results in the exudative phase of ARDS, they have a very quick decline in the forced vital capacity. They really have a tough time expanding their lungs. And as a result, this results in a restrictive lung profile, very acute drop in the forced vital capacity. So we classify this as an acute restrictive lung disease. Okay, a lot of complications occur in the exudative phase of the acute respiratory distress syndrome. It's very difficult to keep these people out of trouble. We have to keep them oxygenated. Usually it requires putting them on a mechanical ventilator. There are a number of complications, including infections of the lungs. So we have to give them antibiotics accordingly. However, if they survive the acute exudative phase of ARDS, their lung might start beginning to repair itself. Now, this occurs in what we call the proliferative phase of ARDS. Now, we got a problem. Let's take a look at the problem. And we have an alveolar wall that's completely denuded of any kind of epithelium. Here's a section through the wall. There's the airspace right there. There's the wall of the alveolus. Normally, the wall of the alveolus is mostly infested by these squamoid type 1 pneumocytes. They're kind of designed to promote good gas exchange, low profile, easy for gases to get in and out of the blood through these type 1 pneumocytes. They also act as a barrier to infection. They're the first line of defense against any kind of bacteria that might try to invade the lungs. Well, they've been completely removed from the wall of the alveolus. The alveolar wall is denuded of these type 1 pneumocytes. Now there's no barrier. Bacteria can go right through there and infect the subepithelial tissues. These people are wide open for attack for any kind of infection. Now, the logical thing for the body to do would regenerate this type of epithelium by causing these type 1 pneumocytes to proliferate and repopulate the entire wall of the alveolus. That would be the logical thing to do. Unfortunately, these type 1 pneumocytes don't have much proliferative capacity. So instead of leaving this area just bare, we got to invest it with some sort of barrier, some sort of epithelium. Instead, what happens is these type 2 pneumocytes, these bulky type 2 pneumocytes, they enter into the mitotic cycle and they line the entire wall of the alveolus. Now that creates a nice barrier through which bacteria can't pass, and it restores the integrity of the lungs' defensive mechanisms. But look how bulky they are. They're not designed for good gas diffusion. And when these type 2 pneumocytes reinvest the walls of the alveoli, a person's gas diffusion capacity is considerably compromised. Gases just can't pass through those very bulky cells. Now, for a time, the person's gas diffusion capacity is very limited. Ability to oxygenate, blow off CO2 is very limited. Fortunately, eventually what will happen, again, if they survive this phase, is these type 2 pneumocytes will differentiate to squamoid type 1 pneumocytes, but it takes time. Altogether, from beginning to end, it takes about 4 to 6 months for this whole cycle to complete itself. Once that happens, the person's pulmonary function should be restored. But there are many complications along the way that could complicate matters and could cause some sort of terminal illness. Okay? At one point, ARDS was associated with almost 100% mortality due to all the complications, problems with oxygenating, problems with blowing off CO2, infections. The mortality is virtually 100%. Now we've got the mortality down to about 40%. So you see, there are still many complications that have to be managed as a result of the degeneration of the defenses of the lungs and the compromised gas diffusion capacity. Okay. Let's take a look at some of the different things that can cause ARDS. So here are some of the things that can cause acute lung injury that ultimately can lead to ARDS. Big on the list, sepsis, septicemia, especially gram-negative types of septicemias. Okay, that gram-negative septicemia causes endotoxemia. You can have gram-positive septicemias, but those are not associated with endotoxemia. Gram-positive bacteria don't make endotoxin. They make exotoxin. They don't make endotoxin. Okay. Some other things. Here's an interesting one: gastric aspiration. If someone aspirates the acidic contents of the stomach into the lungs, that can cause a lot of damage. Okay. This sometimes happens during very invasive types of surgeries. A person's going on some general anesthesia. We ask them not to eat, before the night before surgery. We want to reduce the gastric volume as much as possible to reduce the possibility they might aspirate under the conditions where they're being surgerized and they're undergoing general anesthesia. Okay, that's why we ask people not to eat. Okay, and we got some other interesting problems. Oxygen toxicity. Inhaling pure oxygen for a long period of time. O2, molecular oxygen, can be transformed into the superoxide free radical. And that superoxide free radical can do a lot of damage to the lung. So we have to be kind of cautious in giving people pure oxygen. And the last one I'll point out, types of drug overdoses that can cause some degree of acute lung injury as well. Okay. Any questions on that?
Wait, sorry, the last one, what did you say? What was the last one?
Chemical injury,
Oh.
heroin, methadone. You can see there are many others, pancreatitis, uremias.
When you talked about the exudate, did you say anything about loss of sulfate?
Loss of surfactant,
Yeah.
yeah, because the type 2 pneumocytes are just as damaged as the type 1. No surfactant. Again, there's so many things contributing to a loss of forced vital capacity, necrotic material accumulating, inflammatory infiltrate accumulating, loss of surfactant. Okay. Workup for ARDS is going to include, of course, a chest radiograph. There is going to be a significant compromise in the person's ability to remain oxygenated, decreases in lung compliance. Again, lots of inflammatory infiltrate, especially in the interstitium of the lung. Those will be the walls of the alveoli. Ultimately, microscopically, you will see degeneration of type 1, type 2 pneumocytes and the pulmonary capillary epithelial cells. Okay, those are some of the features that characterize. Anything else?
In your paper, you said low PO2.
What's that?
In your list, you said low PO2.
I can't understand that word.
You said low PO2, PO2 on your list.
Low P. I'm hearing low PO2.
That's
Low
what you,
Low P.
O2,
Low O2. Low
P.
O2.
PO2.
because you put the P on front.
Yes, partial pressure of oxygen.
Partial pressure.
That's why I did that. P, yeah.
You don't know the PO2?
I'm gonna nickname
don't know
it
that?
Piocho.
The PO2?
Just yeah.
I'll leave.
Got this to compete with, whatever. Chronic restrictive lung diseases. I'm making fun of me, not you. Chronic restrictive lung disease. Okay, so again, the key feature of this is scarring of the interstitium. Scar of the interstitium, scar tissue being replacing the elastic tissue. Imagine how difficult it's going to be to expand the lungs if you have all this scar tissue instead of the normal elastic tissue. Okay, well, that's what happens. The interstitium scars down. That is a common feature of all these different chronic restrictive lung diseases. let's take a look at some of the examples. Idiopathic pulmonary fibrosis, IPF. Now that's an interesting one. Cause of this particular disease is unknown. It's thought to be caused by the inhalation of some sort of antigen an individual is sensitive to. Maybe an antigen that's found everywhere in the environment, you really can't avoid it. It'll activate a series of inflammatory mediators that are very fibrogenic, meaning they cause scarring. And all of this fibrogenic chemical accumulates in the interstitium and eventually causes the lungs to lose the compliance. This happens gradually over time, and it generally happens in small little microscopic patches of the lung at a time. Let's take a look at an example of how this is thought to happen. This is the current theory we favor to explain the pathogenesis of idiopathic pulmonary fibrosis. Okay? It seems that the problem begins with some sort of unknown antigen to which the individual is sensitive to. They inhale this antigen, it's probably something ubiquitous in the environment, can't avoid it really. It'll activate B lymphocytes and T lymphocytes. The B lymphocytes combine, the B lymphocytes differentiate in the plasma cell. The plasma cells elaborate immunoglobulins that combine with the antigen to form these immune complexes. Those in turn will activate things like alveolar macrophages. At the same time that's going on, you got the T lymphocytes being activated. They're going to elaborate cytokines that activate these macrophages. Now, the activated macrophages, they start doing a number of things, including elaborating these fibrogenic chemical mediators that cause fibroblasts to migrate in the lung and proliferate and lay down collagen. This is what scars the interstitium of the lung. At the same time this is all going on, you get a degeneration of the type 1 and type 2 pneumocytes, as well as the pulmonary capillary endothelial cells. And so there might be some exudate in the lung as well. Now, you might think that looks exactly like ARDS, except in ARDS, you get a degeneration of type 1, type 2 pneumocytes and endothelial cells throughout the entire lung at the same time. The entire lung is affected at the same time, and the symptoms are very profound and acute. However, in idiopathic pulmonary fibrosis, these degenerative changes and scarring occurs in little microscopic patches. They occur in little microscopic patches here, there, over there, and it occurs over a long period of time. Now, eventually, these little patches of scar tissue will consolidate, and eventually the whole lung scars down, but it takes a long time. And so, as a result, the forced vital capacity in this disease drops gradually over a period of years. And once the scar tissue forms, of course, you can't reverse it. You can't reverse the scarring. And so there's a gradual decrease in the forced vital capacity. Okay, let's take a look at this. Again, this is a disease that has two different phases, exudative phase and a proliferative phase, except remember that each one of these phases is affecting a little microscopic patch of lung at a time. Here is the exudative phase of idiopathic pulmonary fibrosis. The person inhales the antigen. There's some sort of inflammatory reaction. You can see we've got alveoli here. We've got the interstitium here. Alveolus fills up with exudate. You can see it's dark pink staining material in the alveolar space. That's all exudate. Okay, this would be the exudative phase. Now, again, person who first experiences the beginnings of this disease, pretty asymptomatic because this is a small microscopic patch of lung that's affected. They probably be relatively unaware. Okay, if they had any kind of symptoms at all, it might be a mild cough, but the cough is not going to be productive because there's not much exudate in the alveoli. It's just kind of a small patch here that's affected. Other than that, there are no other symptoms. Eventually, the small microscopic patch of lung will be repaired, except it's going to be repaired with extensive scarring due to the immune system's activation by the antigen. So this is what the exudative phase looks like. Here's what the scarring phase looks like. The proliferative phase of the disease looks like. Again, you can see the individual alveoli here, all little spaces. Okay, and you can see the walls here. Look how thick the walls are. That's all thickened with scar tissue. If you've got a lot of scar tissue like this in the interstitium, imagine how difficult it's going to be to expand that lung. It's like trying to tug on the same kind of connective tissue your tendons are made on. Your tendons aren't going to stretch. This lung is not going to stretch either. It's got all of this scar tissue in the wall. Okay, this is the proliferative phase of idiopathic pulmonary fibrosis. Now, again, this is kind of an insidious disease because it's occurring at a very small microscopic level. And so the person initially is completely unaware. Again, maybe a cough, a dry cough here or there. Eventually, though, they're going to start developing symptomatology. You're going to find that they have to labor to breathe. It's very difficult to expand their lungs. And what's happening is that these little microscopic patches over the years are starting to consolidate. They're starting to form solid areas of scar tissue in the lung. Okay. Now, typically, this disease affects older individuals, usually people over the age of 60. In order to make this diagnosis, you really have to exclude every other cause of scarring of the lung. There are many things that can scar the lung. Some things are treatable, some things are avoidable. When you give someone a diagnosis of idiopathic pulmonary fibrosis, basically you're telling them, well, we don't know what's causing this problem. There's really no way to treat it effectively. And basically you're saying, well, in a few years, maybe 4 or 5 years, you're going to succumb to the effects of the reduction in pulmonary respiratory efficiency. Something that's going to happen related to some pulmonary failure or cardiorespiratory failure. Basically, you're giving them pretty much a death sentence when you give them an IPF diagnosis. So we have to exclude everything else that could possibly cause this. If it is something that we can treat, we want to be able to identify it. After we've excluded everything else, then we kind of like, well, we give up. I mean, this is idiopathic. We don't know what caused it. That's why it has a designation as a diagnosis of exclusion. You have to exclude everything else before you make this diagnosis. In the end, there's extensive changes in the lungs. You can see it on a radiograph. Okay, we have normal radiograph within normal limits, and we have an example of end-stage idiopathic pulmonary fibrosis. Okay, take a look at the normal. We have normal cardiac silhouette. The hemidiaphragms look good. Lucency of the trachea is good. You can see vascular markings in the lungs, nice clear lungs. Hilar radiodensities look good. Everything about that looks good. And when the interstitium scars down, it becomes very thick. There's still air in the lung. There's still a lot of air in the lung. It's just that the walls of the alveoli are very thick. And when you take a radiograph of a lung with very thick alveolar walls, the lung fields start to look hazy like this. They still have a lot of air in them. You can see there's air density in there, but it's kind of hazy. And that's because of the thickened walls of the alveoli that cast a more of a radiodense shadow in the lucency of the lung fields. Now, if you look carefully, you can see there are a lot of lines in here. It's kind of a reticular pattern, a web-like pattern. That's consistent with interstitial disease that affects the interstitial lung as opposed to the air spaces of the alveoli themselves. And we're going to talk about more of that later, but this is typically an interstitial pattern caused by scarring of the interstitium. Now, if you look carefully, you'll kind of see these lines in some cases make kind of a honeycomb pattern. Okay, this is called honeycombing. Honeycombing, again, is kind of another word that refers to interstitial disease. Okay. Very extensive interstitial scarring here. Now, this person probably has a significant reduction in the forced vital capacity, and it's because of all that scarring.
What did you say is lucid? How did you call that, lucid?
Honeycombing. Oh, lucency. That's lucent. The dark areas.
And the other one you call what?
Well, generally you describe these radiodensities, with a kind of a relative language. That's radiolucent. That's radiodense. Okay. Do you know about the 5 different radiodensities we generally use to reference things? Okay, you've all heard of that. 5 radiodensities.
Mhm.
Got the air, fat, water, bone, metal, etc. Okay. So I can say that's an air radiodensity. There's a water radiodensity. There's another air radiodensity. Bone radiodensities. Okay,
They never tried like stem cell injections from patients that have the IPF, to, like see if they
stem cell
proliferate.
injections, the problem is not so much regeneration, it's trying to break down the scar tissue. It's interesting to see that if if you were going to treat it, you would try things like steroid to try to reduce the inflammations, progression of scarring. The other thing, I suppose if you tried to break down the scar tissue, like a collagenase or something, you might be able to break some of that down, but it would probably affect the airways as well. And you probably develop like an emphysema-like disease to replace it. But it's an interesting idea that maybe you could kind of break down the collagen. Okay. Okay. Anything about this? I think I covered it. Right. No questions on this? Now let's take a look at sarcoidosis. Sarcoidosis. This is an interesting disease. This isn't necessarily a pulmonary disease. Actually, sarcoidosis is classified as a multi-system disease. It's a disease of unknown etiology. It's characterized by non-necrotizing granulomatous inflammation, that special type of inflammation. Apparently, it is a disease in which this type of granulomatous inflammation can affect any tissue at all. Very often, though, it'll affect the lymph nodes as well as the lungs. Those are very common in the commonly involved tissues. Now, again, this is kind of a diagnosis of exclusion. Many things can cause granulomatous inflammation. Sarcoidosis is kind of a disease that we just don't know its etiology. So if there is something causing granulomatous inflammation that we can treat, we would like to be able to identify it and treat it. Now, when the granulomatous inflammation starts affecting the lungs, it causes scarring. And again, what's a common finding of a chronic restrictive lung disease? Interstitial scarring. That's what this granulomatous inflammation does. It causes interstitial scarring. Okay. Now, the problem with sarcoid ultimately is this granulomatous inflammation scarring. Some people believe that sarcoidosis is an autoimmune disease. Some people believe it's some sort of infectious disease. Some people believe it's an autoimmune disease triggered by an infection. So there's all kinds of different perspectives of what sarcoid is. And it can present many different ways. It can affect any kind of tissue. Again, often it affects the lymph nodes in the lung, particularly the higher lymph nodes of the lung. But it can present anyway. It can present in any bodily tissue. It can present as granulomatous inflammation. Now, a few of the things we do know about people who tend to develop sarcoidosis. There's clearly something wrong with their immune systems. When we test their immune systems, they display something called cutaneous anergy. Cutaneous anergy. Anergic, not responsive. You're all familiar with the PPD test that we used to test for tuberculosis. Okay. So that's a test for tuberculosis. We take refined proteins from the Mycobacterium genus and we inject them onto the skin. If your immune system has ever seen those antigens before, then within about 48 hours, it's going to mount a pretty decent inflammatory response, and you'll be able to see the results as kind of a erythematous wheal that develops, a very large patch of skin that's elevated and erythematous. Okay, that's what would be a positive PPD test. And of course, if your immune system hasn't ever encountered the antigens of Mycobacterium BB4, you won't get that kind of an immunologic reaction. You won't see the erythema and the inflammatory response. That would be a negative PPD test. Usually in certain individuals, we want to use a positive control when we use a PPD test. We want to inject them with the antigen we know they should respond to, just to test their immune system, make sure it's intact and functioning properly. And usually the antigen we use is the antigens of Candida albicans. It's a yeast. It's found ubiquitously. You can't avoid it. All of us should have encountered the antigens of Candida albicans before. So any one of you injected with those antigens, you should mount an inflammatory response again, a type 4 hypersensitivity reaction to it. When you inject most people, that's exactly what you're going to get. However, people who have sarcoidosis, when you inject them with the antigens of Candida albicans, they don't react to it. That's referred to as cutaneous energy. They don't react. There's no skin energy. Cutaneous is literally what it means. Cutaneous energy, no skin energy. All right. Couple of risk factors very important for sarcoidosis. The disease is 10 times more prevalent in African Americans. Usually your patient's going to be young, otherwise healthy woman. She's going to be under the age of 40, African American, probably present with some sort of chest discomfort. Very often take a chest radiograph, you will see evidence of bilateral hyalurolymphadenopathy, the hilar lymph nodes, most common organ tissue that is affected by this granulomatous inflammation, and it causes those lymph nodes to enlarge. Take a radiograph, you see them substantially enlarged. Okay, let's take a look at all of this. Okay, let's take a look at a chest radiograph typical of someone with sarcoidosis. Okay, we have a normal chest radiograph, and here is again a young woman with sarcoid. So take a look at this chest radiograph. Everything's within normal limits. Again, lucency of the lungs, the diaphragm, very good. Okay, lucency of the trachea, cardiac silhouette looks good. Look at the hilar radiodensities. These are where you find, of course, large arteries and veins and lymph nodes, and these are normally radiodense. Okay. These are typical of what normal hilar shadows should look like. Hilar radiodensity should look like that. Okay. When someone develops sarcoidosis, the most common tissue affected is going to be these hilar lymph nodes in here. And so they're effaced by a chronic granulomatous inflammatory response. And they get big. They develop lymphadenopathy. And usually it's bilateral. So they often present with bilateral hyalurolymphadenopathy. Here's an example with a young woman with bilateral hyalurolymphadenopathy. And you can see the hilar regions here. Notice how prominent the hilar regions are, how radiodense they are. And that's because the lymph nodes in that area are quite large. And they've been effaced by that chronic granulomatous inflammation, and now they're casting a very radiodense shadow there. And that's very often the way someone will present with sarcoidosis. Sometimes this is found incidentally. The person's relatively asymptomatic. Okay, again, maybe they have some mild chest discomfort. They take a chest radiograph for this or some other reason, and they say, wow, bilateral hyalurolymphadenopathy. One of the things on the differential is going to be sarcoid. Now, sarcoid can affect a lot of different tissues. From the hilar regions here, it can also affect the lungs. The granulomatous inflammation can start spreading through the lungs, again, scarring the lungs down gradually. Scar tissue forms in the lungs, the forced vital capacity decreases. Okay, let's take a look at this granulomatous inflammation in the lymph nodes. Let's first take a look at a normal lymph node. Here's a normal lymph node. Okay, there's a diverse population of white blood cells here, lymphocytes, macrophages, blood vessels. There's just a whole diverse population of white blood cells here. Okay, if that's normal, here is what granulomatous inflammation looks like in the lymph nodes of someone with sarcoid. It's a non-necrotizing type of granulomatous inflammation. We have all of these macrophages, some of which fuse to form these giant cells, and they're surrounded by lymphocytes. Can you recognize that white blood cell distribution as being granulomatous inflammation? The granulomatous inflammation has completely effaced the normal architecture of the lymph node. When that happens, these lymph nodes get very large. And you can see them, of course, on a radiograph when they affect the hilar regions of the lung. Now, I mentioned before this type of granulomatous inflammation primarily affects lymph nodes and lung, but it can affect any other tissue. 25% of the time, the skin is involved. They have what we call cutaneous sarcoid. Cutaneous sarcoid. Cutaneous sarcoid is actually where the name sarcoidosis comes from. Sarcoidosis means fleshy, referring to the fleshy lesions that tend to develop on the skin when someone has sarcoid. Typically, 25% of the time, the skin is involved. People with sarcoidosis of the skin will present with kind of these fleshy plaques around the face. Let's take a look. Here's an example of cutaneous sarcoidosis. Okay, this is where the name sarcoid comes from. Again, you can see we have a young African-American woman. Around the area of the nose, you can see there are these fleshy, plaque-like lesions here. This is where the name comes from. Sarcoid means fleshy. Okay. Now, there are other cutaneous manifestations of sarcoidosis. Some people with sarcoid also develop these very painful nodules on the lower extremities, especially the anterior lower extremities. This is called erythema nodosum. Red nodules, erythema nodosum. They're very painful. Okay, and they're remarkable for that granulomatous inflammation. Okay. Going over, we'll just finish up this section. Okay, so we talked a little bit about the risk factors, again, 10 times more prevalent in this one population. Presentation is highly variable because different tissues can be involved with the granulomatous inflammation. Many are asymptomatic, they're caught kind of incidentally on a chest radiograph. You take this radiograph of an individual, they have bilateral hyperlymphadenopathy. Okay. Lymph nodes are commonly involved, the hilar lymph nodes of the lung, some of the trachea. Again, 75% of the cases involve those lymph nodes. About a third of the time, the lungs are involved. And that's where the scarring develops that causes that reduction in the forced vital capacity. They can present with shortness of breath and a dry cough. There might be very little symptomatology associated with it. Again, it's a kind of an indolent process. Okay, skin's involved 25% of the time. I mentioned two manifestations, erythema nodosum, especially lower extremities, anterior lower extremities. And of course, we've got those erythematous plaques in the cheeks and lips. Sometimes the eyes are involved. Okay. Some of the individuals will just present with kind of constitutional signs and symptoms of inflammation, fever, fatigue, night sweats. And again, it's a kind of a very vague presentation. It's got many different manifestations, highly variable presentation because so many tissues can be involved. Okay, the workup, again, you want to identify any other possible causes of granulomatous inflammation. Usually, we can successfully manage this with steroids. You calm down the granulomatous inflammation with steroids. Very often, 70% of the time, people will respond to steroids. 70–90% of the time, people will respond to steroid. Sometimes you get some stubborn cases that just don't respond to steroid. And again, they develop that progressive disease. If the lungs are involved, it will result in progressive drop in the forced vital capacity. Okay, any questions on this? Okay. In that case, all right, we'll pick up on Friday, right? Friday. And as it stands right now, I don't think we're going to have our midterm. So good. Another Monday.